We are continuing with endocrine system. Pituitary pathology, we are going to follow this pattern. Like clinically, the pituitary adenomas, they mimic the endocrine effects. Yeah, like if they are functional adenomas, the hormones they produce, they manifest the clinical manifestations due to excess of those hormones, and the patient can present with mass effects if it's some large pituitary adenoma that compresses the gland and the surrounding structures, and when it compressed the optic nerves on the optic chiasm, it lead to visual effects like bitemporal hemianopia. So we are going to discuss the functioning adenomas and the manifestations required due to excess of those hormones that they secreted by those uh, pituitary adenomas. Hypopituitarism, that could be due to ischemia, due to injury, and due to non-functioning pituitary adenomas, which due to their size can results in loss of pituitary parenchyma. Posterior pituitary syndromes like syndrome of inappropriate ADH secretion and diabetes insipidus, hypothalamic suprasellar tumors like craniopharyngioma. Clinical features of, like, if it's an functioning adenoma and it's hyperfunctioning and producing excess of hormones like growth hormone, it is and that is usually due to acidophil pituitary adenoma. Like acidophils, they are proliferating, and lactational changes like lacturia, or that is due to lactin adenoma, and that is also due to acidophil cells like acidophil adenoma. Like hypopituitarism results in manifestations like retarded growth when it acts decrease in amount of growth hormone, hypothyroidism when there is decrease thyroid levels in the body, and when it comes to an adrenal cortex, hyperpituitarism results in decrease in manifestations due to decreased levels of cortisol in the body. Mass effects, like when there is an adenoma, it compresses the surrounding structures. So, and it's very close. As we have discussed the anatomy of pituitary gland, like it's very inferior to the hypothalamus and is very close to the optic chiasm where the optic nerves cross. So when large pituitary adenoma compress the nerves, optic nerves, it leads to visual field defects like bitemporal hemianopia and headaches. Because when it's stretched the meninges, when meninges are stretched, that leads to pain or headache. Due to its mass effects, it can also impinges on the adjacent meninges and leads to headache. Now, overview of the pituitary adenoma. Pituitary adenoma is a primary tumor of a pituitary gland, and 99% of pituitary gland tumors are benign. As name signifies, it's an adenoma, but pituitary hyperplasia and pituitary carcinoma can also occur in the pituitary gland. Most commonly diagnosed in the age group of 30 and 50 years. And pituitary adenomas accounts for 10 to 15% of all intracranial tumors. Symptomatic due to production of hormones like somatotrope adenoma that produce lectotrope adenoma that produce prolactinomas, and Cushing syndromes due to corticotrope adenoma that produce excess amount of ACTH are found more frequently in women. Pituitary adenomas are basically classified by their cell of origin where they arises, like lectotrope cells in the anterior pituitary glands leads to lectotrope adenomas, and that leads to prolactinomas. Gonadotrope cells are the origin that leads to gonadotrope adenomas, and somatotrope like leads to, if it's the origin of cells as somatotrope, that leads to somatotrope adenoma, and similarly corticotrope leads to corticotrope adenomas, and thyrotrope cells leads to thyrotrope adenomas. And we classify these pituitary adenomas according to their size, like microadenomas and macroadenomas. Micro, if the diameter of a pituitary adenoma is less than 1 centimeter, it's a microadenoma. And if the size is greater than 1 centimeter, it's macroadenoma. Etiology of pituitary adenomas, it's a multi-step and a multi-causal process. It includes initiation and progression phase. Endocrine factors also induce cell proliferation that leads to excess production of hormones like growth hormones, corticotropin, ACTH, or cortisol, or gonadotropin, FSH, and LH. Inherited syndromes are also associated with pituitary adenomas like MAN1 with involvement of 11q13, Carney complex with involvement of 2p16 and 17q, and familial acromegaly is also like with involvement of 11q13. And McEwen-Albright syndrome has also association with pituitary adenomas. Grossly, as we had we classified as micro on the basis of size. If the size is less than 1 centimeter, it's a microadenoma. And if the size is more than 1 centimeter, then it is macroadenoma. Giant adenomas are rare tumors that exceed the size greater than 5 centimeters. Usually functional adenomas are microadenomas because they are detected due to the manifestations of the hormones they secrete, and they are detected early. And macroadenomas are usually non-functioning adenomas because they continue to grow in their size, and they are being not noticed because they are non-functional, and they produce they are not come into notice when they produce their mass effects like pressure effects on the surrounding structures like headache and visual defects. This is the microscopy of the pituitary adenoma. In pituitary adenoma, there is the monotony of the cell. The cells are monomorphic. They are like similar to one another, and they are arranged in the form of sheets. And look at the cytoplasm. It's granular and eosinophilic. So it's an acidophil pituitary adenoma, and we can confirm it with the immunohistochemical stain, and the nuclei are central and round with rare prominent nucleoli, and there is loss of fibrovascular framework that surrounds the normal SNR structures of the pituitary cells, and this can be confirmed by the reticulin stain. This is the immunohistochemical stain growth hormone that is positive in this growth hormone adenoma. Clinically, the pituitary adenomas they present mostly as mass effects, headache, when they due to stretching of the meninges, and visual defects when visual effects when they compress the optic chiasma and the optic nerve where the optic nerves cross, and leads to bitemporal hemianopia due to compression of optic chiasm. Clinical manifestations of hormonal overproduction and the clinical effects due to those overproduction of hormones are, if it's excess production of prolactin due to lactotrope adenoma, it leads to hypogonadism. If it's sustained, and in women, amenorrhea, galactorrhea, and infertility, and in men, there is decreased libido, impotence, and rarely galactorrhea. When there's excess amount of growth hormone due to somatotrope adenoma, that leads to that somatotrope are the pituitary cells that leads to somatotrope adenoma, and excess they produce growth hormone that leads to when it's an adenoma, it leads to excess amount of secretion of growth hormone, And in children and adolescents, it results in pituitary gigantism. And when it's in adults, after closure of the epiphysis, leads to acromegaly, in which there is change in size of hand and feet, coarseness of face, frontal bossing, and progenithism. Further changes in the voice and hirsutism confirm the diagnosis. Acromegaly frequently results in glucose intolerance, with 20% of the patients they progress to diabetes mellitus. Carpal tunnel syndrome is also seen in these patients. Cushing disease. Cushing disease due to corticotropic adenoma that leads to excess production of ACTH, and that leads to Cushing syndrome. And the patient presents with weight gain, central obesity, moon faces, violets dry on abdomen, and easy bruisability. Now, this is galactorrhea, secretion like of milk from the nipple, and in non-pregnant women and it can also male can also present with galactorrhea if when in there is a prolactin adenoma. This is the picture of a gigantic man that is due to excess somatotropin growth hormone secretion before epiphyseal closure. The patient presents with increase in body size and with approximately long arms and legs. Basically, it is due to hypersecretion of growth hormone in childhood or in pre-adult in adolescence, and due to tumor of acidophil cells of interior pituitary. Acromegaly. Excess of somatotropin growth hormone after epiphyseal closure leads to acromegaly, in which there is increase in size of organs and coarse, thick hands and thickening of the skin and special coarse features of face. Acromegaly is an anterior pituitary disorder that is characterized by abnormal growth of hand, feet, and face due to overproduction of growth hormone. There is enlargement, thickening, and broadening of bones and particularly extremities of the body. Cushing syndrome. Cushing syndrome is patients like presents with moon faces and where there is buffalo hump, and classically this purple striae on the abdomen. Causes of Cushing disease is due to hypersecretion of glucocorticoids, mainly cortisol, due to corticotropic adenoma, either pituitary origin or it could be adrenal origin. If it's a pituitary origin, it leads to Cushing disease. Increased secretion of adrenocorticotropin ACTH hormone leads to hyperplasia of adrenal cortex, as its end organ is adrenal cortex. And when the cells they increase in number, they leads to hypersecretion of glucocorticoids. And ACTH is increased by tumor in pituitary basophilic cell. It's due to basophil cells which act on the other organs. Like so, it's in basophilic adenoma. Hypothalamic disorders causing hypersecretion of corticotropic releasing hormones. Can be due to that. Now, patient clinically presents with due to excess symptoms of cortisol with moon face, red cheek, and easy bruisability, pendulous abdomen, red purpose striae on abdomen, thin skin, poor wound healing, thin arms and legs, osteoporosis, decreased bone mass, buffalo hump, and pendulous abdomen. Diagnosis is basically based on measuring pituitary hormone levels in prolactinoma, serum prolactin level, or its inhibitory hormones like dopamine, which usually is like give inhibitory effect on the hypothalamus, Its level can be measured. Growth hormone abnormalities like growth hormone levels, insulin like growth factor 1, which results in manifestations of growth hormone and secreted by the liver. Or oral glucose tolerance test is the most sensitive one, in which high doses of glucose leads to, results in failure of suppression of growth hormone. Cushing disease, 24-hour urine collection of free cortisol or dexamethasone suppression test can be is used. Serum levels of ACTH and thyroid hormones including thyrotropion, TSH, thyroxine T4, and triiodothyronine T3 levels in the blood. Luteinizing hormones, LH, follicular stimulating hormone, FSH levels in the blood. Imaging tests like CT scan and MRI can be done to locate these pituitary adenomas. Complications like it can lead to vision loss as due to their mass effects. Pituitary hormone insufficiency, including diabetes insipidus, hypothyroidism, and hypogonadism, may occur. Pituitary apoplexy, when there is large size of macroadenomas, sudden bleeding can take place or hemorrhage in the pituitary adenomas that due to cessation of blood supply of pituitary gland at the base of the brain leads to pituitary apoplexy, which is an surgical emergency.